joining us for today's educational webinar, Menopause and Mental Health, Optimizing Quality of Life in Midlife. My name is Jolie Busby, and I'm the Education and Training Manager at ADAA. With that, I am very pleased to introduce today's moderator, Dr. Sohae Kim. Dr. Kim is an assistant professor of psychiatry, pediatrics, and obstetrics and gynecology at the University of Massachusetts Chan Medical School. She is a clinical psychologist with subspecialty expertise in perinatal and infant mental health. Her research and clinical work have focused on parents and infants during the perinatal period, as she recognizes this period as a critical time during which identification of at-risk individuals and intervention to mitigate risk can be highly effective with far-reaching implications. Well, thank you for moderating, Dr. Kim. I'm going to turn the presentation over to you now.
Thank you, Jolie, for that introduction. So it is now my pleasure to introduce our speaker, Dr. Leah Susser. Dr. Susser is a reproductive psychiatrist and assistant professor of clinical psychiatry at Weill Cornell Medicine. Her clinical work, academic work, and teaching focus on increasing access to mental health care for women across reproductive stages. She is program director of the cross-campus NYP Weill Cornell Medicine Ambulatory Reproductive Psychiatry Program, which offers specialized mental health care to women during the perinatal period with menstrual cycle-related psychiatric symptoms and around the perimenopausal period. We are delighted to have her today, who brings us incredible expertise on the topic and is a fantastic speaker and teacher. So now I'm going to turn this over to Dr. Susser.
Thank you all for joining us today. So today I'm going to be talking about mental health and menopause and ways we can optimize quality of life for women and ourselves if we're in the midlife period. And I have no disclosures. So before I start, I just want to stress I'm going to be talking a lot about symptoms that cause distress for women in midlife. But this gives a biased picture of midlife for women. There are also so many positive experiences that women can have across this period of time, and that's important to keep in mind as we go through this talk. But today, we're going to be focusing on ways we can optimize symptoms that may be causing distress for women at this time. And so I'm going to start by going over the reproductive phases of a woman's adult life, so we can understand what is happening from a reproductive standpoint around menopause. So we understand what we mean by the term menopause or perimenopause and other terms that I'm going to be using throughout this talk. And then once we have that understanding of what menopause and the period around menopause is, we're going to talk about common symptoms that a woman might experience around this time, and then focus in more on the mental health concerns that a woman might have around menopause. And then we're going to talk about evidence-based treatments for these symptoms with a focus on depressive symptoms, but we're also going to do a little discussion of menopausal hormone therapy. You may have all seen this has been in the news a lot recently, and we're going to go over what the initial concerns were with menopausal hormone therapy that led to the black box warnings that are there. And then we're going to talk about how our understanding of these studies have changed and what our understanding is now that is now driving this push to change those black box warnings and hopefully increase access for women who could benefit from it. And so to start with, let's understand what menopause is in this period of time around it. And so most commonly, we use something called the Stages of Reproductive Aging Workshop, or STRAW criteria, to figure out where a woman is in her reproductive life, in her adult reproductive life. And so this uses the pattern of the menstrual cycle. No blood test, just based on a woman's menstrual cycle, where she is around menopause, where she is in her reproductive life. And it breaks an adult woman's reproductive life into 3 phases: the reproductive phase, the menopausal transition, and post-menopause. And so the reproductive phase is when a woman is, if she menstruates regularly, menstruating regularly. The menopausal transition is when she has very irregular periods. This might be that they come unpredictably, or it might be going months without her period. And then post-menopause is when she's no longer menstruating anymore. The term perimenopause is actually not in the STRAW criteria. It's an older term, but it is one that's commonly used, and I'm going to be using a lot because it's a vaguer, a broader term that I find helpful to use. It encompasses the menopausal transition, so this period of time where there's irregular menstruation, and the early part after a woman is no longer menstruating. And so this encompasses more of the period of time when a woman might be experiencing many of the symptoms we're going to be talking about today. So that vaguer term is helpful today. So let's take a look in a little more detail about these reproductive phases around menopause. And so these 3 reproductive phases are then broken down into smaller stages. You don't have to know the details of any of that. But that first phase, the reproductive phase, at the very end of it, I said during most of it, a woman's still menstruating regularly if she menstruates regularly. But at the very end of it, she does start to have subtle changes in her menstrual cycle. This might be, for example, shorter cycles. So maybe she menstruated every 28 days, and now it's every 24 days, but still regularly. This is important to note and recognize because many women can actually start to have the common perimenopausal symptoms at this time, but it might be under-recognized, or it may not be brought to anyone's attention, or a woman may not realize it's related to approaching menopause and that there are treatments for it because there aren't yet as obvious changes in the menstrual cycle. A woman then enters the menopausal transition when her period lengths are very variable, so varying by at least 7 days. So maybe 1 month she menstruates after 40 days, the next month after 30 days, the next month after 50 days. Then as she goes through the menopausal transition, she starts skipping periods. So maybe she menstruates after 3 months, and then 4 months, and then 1 month. And during this menopausal transition, when periods are very irregular, estrogen levels are very variable, and that's important to note for the symptoms that she might experience. And so estrogen levels get very high and very low, and they go up and down much more than may have just occurred around her menstrual cycle prior to this period of time. And then as she approaches her final menstrual period of her life, her estrogen level might go down and then go down again. And then it's still fluctuating though in the early postmenopausal period. And then a couple years postmenopause, roughly, it gets low and stays stably low and doesn't change. And so you're not having those fluctuations in estrogen levels anymore. The exact timing of when it decreases varies based on the woman, but that's kind of roughly what's happening. And certain symptoms are associated with the changes in estrogen that are occurring in the menopausal transition, and other symptoms are due to the low estrogen levels. And so that's just to give you an understanding of what is happening at this time from a reproductive standpoint that informs our understanding of the symptoms a woman experiences at this time and the treatments. So what is perimenopause like? It's important to once again highlight that it's highly variable. Different women are going to experience different symptoms. They're going to get different levels of distress from different symptoms. But it's important for us to recognize what symptoms are common so that we can identify them when a woman is experiencing them and when she's getting distress from them, or when we ourselves are experiencing them so that we know that we can get relief from them and that there are treatments and we don't have to have that distress. So what are common symptoms that a woman might experience at this time? And so this is initially a laundry list, but then we're going to be going into more detail on several of them. And so common symptoms include difficulty with sleep, feeling very tired, vasomotor symptoms. So this is having hot flashes during the day or night sweats overnight. Irritability is a very common symptom at this time. It can be very distressing. Anxiety, sadness, big changes in mood, brain fog. We're going to go into what that term means. And changes in sexual function, urinary symptoms, urinary tract infections can become very common. So when do these common symptoms occur around menopause? As I mentioned, at the end of the reproductive phase, the very end of it, when there are those subtle changes in the menstrual cycle, many symptoms can actually start then. And so it's important to recognize that even though someone's not technically in the menopausal transition yet, that at this period of time, many of the symptoms can start. But as a woman goes into the menopausal transition, that period of time where there are very irregular periods, symptoms are more likely to occur, can become more frequent, and can become more distressing and impairing. So they worsen often in the menopausal transition. The vasomotor symptoms, the hot flashes and night sweats, when they start and how long they last is very variable between different women. Often they can occur in the menopausal transition. They can resolve in the early postmenopausal period, but then for many women, they can go on for many years postmenopause as well. And so vasomotor symptoms are very common. 80% of women will experience them at some point, but the distress that someone gets from them is highly variable. Some women will have a lot of impairment or distress from them, and other women might have it on occasion and not have so much distress from them. And as I mentioned, how long they last is very variable. The median duration is 7.5 years, but it can last much longer, and for other women, can be very brief. And for many women, it can last around 4.5 years after her final period, after menopause. But this is very variable. There are certain women who will continue having vasomotor symptoms, more than 10 years after the final period. So it's very variable, but in general, it resolves, it gets better in the early postmenopausal period when she's done menstruating. What about brain fog? I want to go over this one in a little bit more detail because it's a very vague term that someone can use to describe so many different things at different times. But there are really specific symptoms that often a woman in the perimenopausal period, in this period around menopause, may be experiencing when they use this term brain fog. Specifically, often it's difficulty remembering words or names or stories, or difficulty concentrating, or with just feeling easily distracted. But what's important to point out is that these are the symptoms that a woman is experiencing. Dementia is very rare at this age. It's unlikely to be dementia. 60% of perimenopausal women will report memory difficulties, yet dementia is very rare at this time, and it's unlikely to progress into dementia. And this can be something that's very much on women's minds at this time if they're having those symptoms. And so that can be very reassuring to know. If you do cognitive testing in someone who experiences brain fog, you can see mild changes. Often the testing is still within normal limits, but it's a change for that individual, for that woman. And that change can be very significant for that woman's experience. It can be very distressing, even if it's not a big change. And specifically, it's verbal learning and memory that seem to be impacted most consistently in studies. And so why do women get brain fog at this time? Well, this is thought to be due to the decreases in estrogen levels. And then difficulty sleeping, the hot flashes and night sweats, anxiety and depression can also all contribute to it. And if you address those, you can help the brain fog, but brain fog is also separate from those. So if a woman gets brain fog, how long might she experience it? I often get that question. So it's unclear exactly how long an individual might experience it, but it's very reassuring that for many women, it will improve or resolve postmenopause, especially the verbal memory symptoms. So now let's focus in on the mental health concerns that can occur at this time, particularly anxiety, depression, and irritability, which are the really big ones. But before we get into those symptoms, I once again want to highlight that midlife can also be a time of positive change and well-being. When you look at the general population, so men and women together, positive affects, so positive emotions increase from one's 50s to 60s. So that's from roughly the menopausal, around menopause to the early postmenopausal period. In the US, the average age of the final menstrual period is around 51. Life satisfaction increases from the 40s to 60s, once again from the perimenopausal period to postmenopause. And the 40s to 60s can be a peak time in someone's career. They may have just gotten the promotion they've been trying for, or they're almost there in a really satisfying time in their careers, or with their family, or with their community, or they have, a peak in their self-confidence at this time. When you look at midlife women specifically, more than half of women report feeling satisfied and self-confident most of the time in midlife. And so while there are many symptoms that cause distress that we want to focus on so we can talk about how to treat those symptoms, it's also important to keep in mind there are so many positive things going on at this time as well. And so what is happening around menopause that can impact mental health? Well, there's lots of change occurring at this time. There are biological changes, social changes, psychological changes. So in terms of biological change, what do we mean by that? Well, there are huge hormonal changes. There are the vasomotor symptoms, the hot flashes and night sweats that women can have, the changes in sleep that can impact how you feel. If you don't sleep well, you don't feel well the next day. And physical changes, which could include a new medical diagnosis. There are big social changes, both positive and difficult. A woman may have just become a mother for the first time, or her children may be leaving the home at this time, or she might have just become a grandmother around menopause, or she might be caring for aging parents. So much that can be going on around her in her life that can impact her mental health in all different ways. From a psychological standpoint, there's this idea of loss of fertility. For women I work with, even if they don't plan to ever have another child, this idea that they can no longer reproduce can really impact them, certain women. And so let's dive in a little bit deeper on the hormonal changes around menopause, because this is going to help us understand how these changes in hormone levels can impact mental health around menopause. And so, as we had mentioned in the menopausal transition, when there's a lot of change in menstrual cycles, skipping periods, unpredictability of when someone's going to get their period, there are huge changes in estrogen levels. Estrogen levels get very high and low, and very erratically, unpredictably. Whereas post-menopause, further out post-menopause, estrogen levels are low and stably low. And so how can these changes, particularly the huge fluctuations in estradiol and menopausal transition right before menopause, how can they impact mental health? So let's talk first about depression and anxiety at this time. So in the perimenopausal period, women are at higher risk of depressive symptoms. They're more likely to get depressive symptoms than later on in life or earlier on in life. However, for women in general, they are actually not at higher risk of having a clinically significant major depressive episode. So while depressive symptoms are common, having an actually clinically significant major depressive episode isn't necessarily. However, women who have a history of major depression in the past, clinically significant episodes of depression that are really significant, are at higher risk of having another episode at this time. And this also is a peak time for suicide rates for women. And so we know that this is really a vulnerability at this time. And so when you look at women 45 to 64, they have higher rates of suicide than women at any other age range. And so higher than when they're younger or older. So this is high risk time for depression. What about anxiety? Well, anxiety is not as well studied as depression at this time, which we find it during other periods of time as well. The same can be said about the perinatal period. But we do know that anxiety symptoms are very common at this time, and that women may be at higher risk of anxiety around menopause, but studies are mixed. And so we're going to focus on the biological risk factors. What are the biological risk factors for anxiety and depression around menopause? Well, these changes in estrogen levels that we're getting in the menopausal transition, we know that's associated with both anxiety symptoms and depressive symptoms. And it seems to sensitize women to feeling the emotional impact of a stressor. And so when there are stressors, they feel more sensitive to them. They feel more likely to get anxious or depressed with those stressors. And then we know that vasomotor symptoms also increase the risk of both depressive and anxious symptoms at this time. Now, what about irritability? So, irritability is a big one. Irritability is very common in the perimenopausal period, and it is very under-recognized. And so it's important to recognize it because it causes a lot of distress. And by recognizing it, we can get relief from it if someone's experiencing it. So irritability is very common. It's the most common mental health symptom reported in the perimenopausal period. If you ask women in the past 3 months if they've experienced irritability in the perimenopausal period, more than half will say they have. And if you take a higher risk group of women, so women who have mild depression, and you follow them for 8 weeks, 82% of them may report that they have moderate or severe irritability. And so irritability is very common and can be very distressing in the perimenopausal period. Now let's talk about treatment. We talked about the symptoms, and it's important to know that there are evidence-based treatments for these symptoms to give relief so that we can optimize quality of life for women in midlife. And so, as at other times, the important components to think of when thinking about treating perimenopausal symptoms, and we're going to focus mostly on depression here, are psychotherapy, lifestyle modifications, and I'll go over what I mean by that, and if needed, medication. So what psychotherapies can help perimenopausal symptoms at this time? Well, cognitive behavioral therapy, or CBT, either in group or individual formats in the perimenopausal period, can reduce many different perimenopausal symptoms. It improves depressive symptoms, but also sleep problems, sexual concerns, anxiety symptoms, and both the distress and impairment from vasomotor symptoms, and can improve quality of life in the perimenopausal period. Mindfulness-based stress reduction, so focusing on mindfulness, can improve mood symptoms and physical symptoms at this time as well. And it can actually be used to prevent perimenopausal depression. So if you take women who are feeling well and then they enter the menopausal transition and they're in this treatment, in this psychotherapy, you can help prevent them from getting depressive and stress symptoms. And this is particularly true if that woman happens to have sensitivity to mood symptoms with these changes in estrogen levels, or if they have more stress around them. So what are the lifestyle modifications that can help depressive symptoms at this time? It's similar to at other times in life as well. And so targeting sleep, helping a woman sleep better, is going to help her mental health. Targeting the vasomotor symptoms, treating the hot flashes and the night sweats will help her depressive and anxious symptoms. Exercise is very important, and minimizing stressors when possible. All are going to make a big impact in her mental health and her physical health. What about medications? So serotonin reuptake inhibitors are considered the first line medications for depression around menopause. We have actual well-designed studies some well-designed studies for serotonin reuptake inhibitors for depression at this time, whereas for anxiety, it's really our studies at other times in life for depression that we can then extrapolate to this period. Once again, anxiety is not as well studied as depression, despite how common it is at this period of time. Serotonin reuptake inhibitors can also help vasomotor symptoms, the hot flashes and night sweats. And the FDA has actually approved paroxetine for this indication, but there's also evidence for some other serotonin reuptake inhibitors and that they can help the vasomotor symptoms also. So now what about menopausal hormone therapy and perimenopausal depression? So I want to first highlight menopausal hormone therapy is not FDA approved. It is not an approved indication for perimenopausal depression, but is there any evidence that it might help mood in the perimenopausal period? So before we go over that, I want to give a little overview of what menopausal hormone therapy is, so we all know what we're talking about. And so menopausal hormone therapy is giving low amounts of estrogen or estrogen plus a progesterone or a progestin post-menopause. The progesterone or progestin is needed in addition to the estrogen if a woman has a uterus, because if you give just estrogen and a woman hasn't had a hysterectomy, she still has a uterus, then this can increase her risk of cancer, of uterine cancer, endometrial cancer. And so that's why it's important to include the progesterone. And so what are the FDA indications for using menopausal hormone therapy? Vasomotor symptoms, prevention of osteoporosis, and urinary and sexual function symptoms, such as vaginal dryness. And so can menopausal hormone therapy help mood in the perimenopausal period? Well, there's some evidence that it can help treat depression in the menopausal transition when a woman is having these big changes in estrogen levels, but not post-menopause once the estrogen levels are already stably low. And so it's thought that maybe it's stabilizing those changes in estradiol levels a little bit, that can help mood. If someone is on a selective serotonin reuptake inhibitor, and they've gotten some help from it, but they're still depressed, adding on estrogen may also help them get better more. And there's some evidence as well that giving estrogen in the perimenopausal period, particularly in this early part of the menopausal transition, when they just start to have the changes in estradiol levels, that this can help prevent women from getting depressed, maybe by stabilizing the estrogen when they're just starting to have those big changes in estrogen levels. So in summary, for menopausal hormone therapy and perimenopausal depression, it is not an FDA-approved indication for menopausal hormone therapy. However, if menopausal hormone therapy is being started for a different indication, such as the vasomotor symptoms, it may have a mood impact for that woman. And so let's go into a little bit of detail about the risks and benefits of menopausal hormone therapy. And why I added this to the talk is because it's been in the news a lot. And so I thought that many people might be interested in hearing a little bit more about it. It's timely. Why there were such initial concerns that led to these black box warnings on menopausal hormone therapies, and why there's the push for change now that we understand those studies better. And so the initial concerns about menopausal hormone therapy came from studies in something called the Women's Health Initiative. And so this had a trial for estrogen plus progestin and a trial for estrogen alone to try to see whether these hormone therapies could help prevent chronic diseases such as coronary heart disease, for example. And these studies use a specific kind of estrogen and a specific kind of synthetic progestin. So progestin just means it's a progesterone that's synthetically made. It's not the natural form. And that's important to note because we tend to use different estrogen and progesterones now. The mean age of the women in this study is also important to note, over 63 years old. As we mentioned, for many women, the symptoms can resolve a few years post-menopause for the vasomotor symptoms. And so if a woman has vasomotor symptoms and is going to start menopausal hormone therapy, most of them are going to start at much younger than this. And so this study had initial concerns leading to the trials being stopped early. And the concerns were about breast cancer risk, stroke, and pulmonary embolism. And so what were the findings and limitations of those initial interpretations that led to these concerns? And even though there was one trial with estrogen plus a progestin and another with just estrogen alone, for the purpose of time, I'm going to focus in on the estrogen and progestin study only. And so initially, in this estrogen plus progestin study, there was concern of increased risk of pulmonary embolism, stroke, breast cancer, deep vein thrombosis, and if you looked at all cardiovascular events together. Now that sounds concerning, right? They did not find a difference in cardiovascular disease-related deaths, coronary heart disease, or all-cause mortality. And they found that there was actually protection with the estrogen plus progestin from fractures. So it can help prevent osteoporosis and fractures. Initially for colon cancer, though with longer-term follow-up, this no longer was the case. And then it helped prevent endometrial cancer. But there were problems with the initial interpretations of the studies. It misrepresented what the risk of menopausal hormone therapy was for women who were younger, women who were 50 to 59 years old, or within 10 years of menopause when they started the menopausal hormone therapy, which is when most women are going to start it for the vasomotor symptoms and perimenopausal symptoms. When the study was initially interpreted as well, there was under recognition of all the benefits that menopausal hormone therapy provided women. And as a result, the FDA required that menopausal hormone therapies have certain warnings on them for pulmonary embolism, deep vein thrombosis, stroke, heart attack, breast cancer, and for people over 65, probable dementia. This led to underprescribing. And so women who were having distressing vasomotor symptoms were either afraid to start it or not being offered it because of the over-perception of the risks and the under-perception of the benefits. And so what were the limitations with the initial interpretations? Well, the risks and benefits depended on the age group of the women and how far out they were from menopause. And so women who were 50 to 59 years old or within 10 years of menopause were not at the same risk for these consequences, these risks, as older women. Different estrogens and different progestins that were used have different risks as well. And we don't necessarily use what was used before in this study. And if you give estrogen orally or vaginally or transdermally, the risks are like on a skin patch, the risks aren't the same either. And so once they looked at specifically younger women or women within 10 years of menopause, the risks were much lower. There was still risk of deep vein thrombosis and breast cancer, but pretty small risks. Older women did have more significant risk though. And they did not find an increase in deaths, in mortality from cardiovascular disease, cancer-related, or all-cause, so from anything. And so it wasn't, these risks weren't leading to death. And there are really significant benefits from menopausal hormone therapy. It treats many common perimenopausal symptoms, which improves quality of life, including by treating the vasomotor symptoms. It decreases fracture risk, which is, really concerning in older women. And so the benefits is important to note. And we also know that from this trial, there was only estrogen alone, that the risk of breast cancer actually wasn't seen. And in fact, it reduced the risk of breast cancer and breast cancer deaths. And so was this because estrogen plus progestin together have a different risk than estrogen alone? Or was it the progestin used in that study that was carrying the risk rather than the estrogen? And similarly with estrogen alone, there wasn't the risk of cardiovascular disease. And actually in younger women, there was some decrease in this risk. So the take-home message is that for women who are healthy within 10 years of menopause or under 60 years old, menopausal hormone therapy is low risk. And the bothersome vasomotor symptoms, it can really help, and these benefits can often outweigh the small risks. and that the estrogen and progestin used in that study don't necessarily have the same risk as the formulations we often use now. And so just to conclude, the perimenopausal experience is highly variable, but there are common symptoms that women can have, and it's important to recognize them so that we can get relief from those symptoms. There are treatments that can reduce distress from these common symptoms.
Thank you, Dr. Susser. I'm seeing questions coming through in the Q&A. For those of you who have questions for Dr. Susser, please use the Q&A Zoom toolbar, and we might not be able to get to all of it, but we're going to try our best. First of all, I see a lot of questions about surgical menopause due to cancer treatments, chemo, hormone suppressants. If you could speak to that, especially in the case where surgical menopause happens at an earlier age. Just in general, some questions are asking how long these symptoms last and if there are different treatment recommendations.
Yeah, those are excellent questions. For early menopause or menopause due to removal of the ovaries, surgical menopause, there are differences in treatment recommendations for the symptoms, and the duration of symptoms also can be different. Prevention of osteoporosis can be really important if a woman experiences menopause, at a younger age, for example. Then having estrogen replacement isn't necessarily just for symptom relief earlier on, but if she, not for a surgical reason, but let's say she has early menopause, at 35 years old, then it would be important to have estrogen for protection of various different diseases, including osteoporosis.
Thank you. Someone is
And also if there's,
Go ahead.
Go on to the next question. Yeah.
Someone was commenting after surgical menopause whether the body adjusts to having zero hormones rather than a consistent dose of HRT.
What do you mean by that?
I'm going to ask the person who asked the question to maybe clarify. Seems like the attendee was asking whether after a while in surgical menopause, whether the body adjusts to having zero hormones in the body.
So the estrogen level, when it is stably low, a woman will get symptoms of the low estrogen. So for example, risk of osteoporosis or vaginal dryness or other symptoms that or frequent urinary tract infections can occur, other things that are associated with that low estrogen level.
Thank you. There are also a lot of questions around medications. First of all, quick clarification. Are MHT and HRT the same thing?
Well, that is an excellent question. So the terms used for menopausal hormone therapy have changed so much over the years. And so just the current term used is menopausal hormone therapy. At other times, it was called hormone replacement therapy, but now we know that it's not really to replace the hormones to the same degree. And so, so the terminology is just changed with time, but it's all referring to the same thing.
Also, a lot of questions around once you start HRT, how long do you stay on it? What does the research say about it? Can you go off at some point?
Yeah. So that's a really important question, actually. It's recommended to only take as long as a woman needs it. And so if a woman, is no longer having bother from the symptoms it was started for, then at some point trying to come off it and seeing if she still needs it to reduce the risks that there are.
You mentioned earlier there was a slide about using estrogen, but not another medication that could more likely increase risk of cancer in women without hysterectomy. This attendee asked a question and then sort of answered, but there are other attendees also asking just the different medication options in the case of having hysterectomy versus not. For example, do women need progesterone if they had their uterus, ovaries, and fallopian tubes removed?
That's a really great question. So they don't need the progesterone if they don't have their uterus anymore. So a hysterectomy is when you have the uterus removed. And if you have your uterus removed, then you don't have that risk of the estrogen alone on your uterus that can increase your risk of cancer. And so if the uterus is removed, then you only need the estrogen. You don't need to add the progesterone to it.
Thank you. There are also a lot of questions around finding the right doctor. How do you find a doctor who's educated in perimenopause and hormone-related treatments? Some attendees are sharing it's really disappointing experiences of being dismissed due to their age or looking like they're not really struggling and so on. So any thoughts and suggestions around that?
Yeah. So the Menopause Society does have a sort of kind of credentialing system for gynecologists that can be a helpful list, but it can be really hard to find people who are specialized in the period and feel comfortable prescribing menopausal hormone therapy. But hopefully, as the black box warning labels change, more and more clinicians will feel comfortable offering it to women. And so I think that'll be a really important move so that more women can have access to menopausal hormone therapy. I just want to go back to one of the other questions about surgical menopause as well, and just other groups of women as well, and what differences there might be in the treatments. One thing that I didn't include here for the purpose of time that could be helpful to mention is women who might be having significant vasomotor symptoms, who have a history of, for example, estrogen positive breast cancer, or have a history of different clotting disorders or other things that can place them at higher risk of being on an estrogen. There are now also non-hormonal. In addition, I mentioned that serotonin reuptake inhibitors can help relieve the vasomotor symptoms, but there are also now something called neurokinin antagonists, and they're non-hormonal medications that can relieve vasomotor symptoms.
There are lots of questions. I think I saw a question related to what you were commenting on. I think it was, is there a natural alternative to HRT?
So it's not by natural, the natural is a complicated term, but in terms of medication that we might give that is more similar to what we had in our bodies, there are formulations, for example, of progesterone that we use now instead of what they use in that study, the synthetic version, that is closer to what we have already in our body. And same with estrogen. So in that study, they use something called conjugated equine estrogen, which is from horses. And these days we use 17 beta estradiol, which is what we naturally have in our body. And so we are using what we kind of consider more natural versions of the hormones. In terms of, if you mean non-medication, for overall health and perimenopausal symptoms overall, exercise is so important. Sleep is so important. There's so many factors in our day that improve mental health and physical health symptoms, and are so important for our health overall.
Any support groups or resources you can recommend?
The Menopause Society has really is the place to go for those resources.
There's a question about whether these perimenopausal symptoms are more prominent in Black women. If you can speak to any racial or ethnic differences.
Yeah, and that is such an important question. There are differences in what symptoms women of different races and ethnicities experience. Certain women experience more of the joint pains, other women the vasomotor symptoms, and so there are differences. And this is really important to appreciate.
There are also questions about birth control and HRT and perimenopause. So, what does perimenopause look like for women who have continuously been on birth control? And also, there are cases where birth control pills are prescribed instead of HRT. Is that common? Any thoughts on that?
Yeah, that's a great question. So oral contraceptive pills or birth control pills, a combination of an estrogen and a progestin, again, actually use higher levels of estrogen than are in the hormone replacement therapy. And the reason for that is that they have to be a contraceptive. They have to prevent pregnancy. And they block ovulation, which means it's it needs to be a higher dose to block ovulation. And so when a woman is not yet postmenopause, when she's either in her reproductive phase or in the menopausal transition, birth control pills are actually what are going to be used and what are often used for these vasomotor symptoms or for, in some cases, for the premenstrual symptoms that a woman might have, or to regulate her period. And then post-menopause, when she's no longer menstruating, she doesn't need the contraceptive anymore, and she doesn't need something that blocks ovulation to stabilize the estrogen levels. And then you would use the menopausal hormone therapy. So it's really post-menopause that you're going to be using the menopausal hormone therapy.
For someone who's in postmenopause who is on HRT, how long does it take to settle the hormone fluctuation?
Yeah, so post-menopause, after the first couple of years, it's actually stably low levels of estradiol. So the menopausal hormone therapy, when it's being used for the indications that we use it for that are FDA indicated, like vasomotor symptoms, it's it doesn't need to stabilize them. It's just giving a little bit of that estrogen back. But in the menopausal transition, when you're using birth control pills for the vasomotor symptoms or other symptoms, for that you are blocking ovulation to stabilize the hormone levels. So I guess within a cycle, but I don't know more specifically than that.
Yeah. And also relatedly, when would postmenopause end? I'm assuming without any treatment, those symptoms, when would it end?
Oh, yeah. So the symptoms of postmenopause or postmenopause, the period? I'll answer both. Postmenopause, the phase of life goes on for the rest of a woman's life. But in terms of the symptoms, the different symptoms, it's different. For the hot flashes and the night sweats, those vasomotor symptoms, it usually ends around 4 or 5 years postmenopause, but there's a huge variation. And so some women will have it just very briefly in the menopausal transition or just right after menopause. And then there are some women who can get it, for more than 10 years after menopause. But usually it ends a few years after the final period of a woman's life. Brain fog, we don't really know exactly when it gets better, But it seems like if you then look at women further out post-menopause, that for many women it then improves or resolves. For depressive symptoms, if a woman has no history of depression before and now she's experiencing depressive symptoms in the menopausal transition, it usually resolves within 2 years of her last period of life. So 2 years into postmenopause. So for the different symptoms, it's different. And for the sexual function symptoms and urinary symptoms, those are going to last postmenopause because they're associated with many of them are associated with the low estrogen levels.
So just a faceless voice. We're doing great on time. I think we have time for maybe 2 or 3 more questions.
Thank you, Jolie.
Great.
Lots of questions about risk and side effects of HRT. Is there any particular kind of MHT, HRT that you would recommend that is most risk-free and has the least side effects? Also, relatedly, there are some questions about route of administration, risk and benefits of different options.
Yeah. So this was really the study I presented was using forms that we don't use as commonly today. The best design study we have. We don't have the same sort of ongoing large studies of many of the formulations we have today, but it'd be so helpful to have them. There is quite a bit of evidence though that route of administration does make a big impact. And so if someone's just using a vaginal cream for vaginal dryness, for example, there's even evidence that it's low risk in women with breast cancer, for example. And so risks seem to be a lot lower for estrogen that's not getting as much all over the body. There's also some evidence that, or some theoretical reason to think, but we need studies to actually show this, that the estrogen patches, so transdermal estrogen, may have lower risk for clotting. And so, but we need longer term studies to really understand those things. And then for the different progestins and progesterones, different types bind different places in the body and have different risks. And so there's some thought that the progestin that was specifically used in that women's health initiative has risks that other ones may not have.
Can you speak to brain fog as it relates to ADHD in terms of how to distinguish between the two? And also, if you could speak to changes in dopamine and other hormonal fluctuations in relation to ADHD and neurodivergence.
Yeah. So for ADHD, in terms of brain fog and ADHD, brain fog, often what's noted is difficulty in the verbal memory and verbal learning. And so women often will experiencing, difficulties remembering a word or a name. And in many cases, executive functioning, which is also often impaired in ADHD, is not impacted. It's kind of mixed in the literature, whether that's impacted at that time. And so there is evidence, though, specifically if someone is having those executive functioning difficulties in the perimenopausal period or experiencing worsening ADHD, that lisdexamfetamine can really help those symptoms in the perimenopausal period.
There are also questions about testosterone fitting into the treatment plan. Could you speak to that?
Yeah, there's a lot more recently on testosterone, but I think that to go over that thoroughly would be a whole other talk, especially since it's much newer in the literature and with a lot of complexities.
Do we have time for one more question, Jolie?
One more question, and then we'll wrap it up.
Yeah. I know you mentioned this during the presentation, but there are questions about how early to start taking HRT, and is there a cutoff age? And I imagine that has to do with the increase in risk
Yeah.
that you presented. So if you could speak to that.
Right. Usually If someone's still menstruating just irregularly in the menopausal transition, often then a birth control pill would be used. And so usually it's, a year after someone's final menstrual period, when they're now post-menopause, that you would then go for the menopausal hormone therapies for the symptoms in general. And how far out? Usually it's recommended if you're going to start it to really start it in women who are under 60 years old or within 10 years of menopause, because it's higher risk after that time. Though there is now discussion between researchers and clinicians who work with women at that time, that if someone is still having significant symptoms and they're lower risk at that time, might it not be fully contraindicated, but for some women, might it still be appropriate? There's a lot of discussion about that, but it's lower risk when it's started within 10 years of menopause or before 60 years old.